the rationale for PDIGREE really relies on two phase 3 trials in particular, Checkmate 214, which showed that the doublet of ipilimumab nivolumab improved overall survival outcomes in patients with metastatic clear cell kidney cancer, as well as Checkmate 9ER, which showed the doublet of cabozantinib with nivolumab also improved both progression-free survival and overall survival for these patient populations. And so PDIGREE was really thinking about the adaptive approaches of these doublets and how can we use these doublets more effectively in sequence. So PDIGREE was designed as a phase 3 adaptive trial with all patients with intermediate poor risk disease treated with ipilimumab nivolumab as step 1 of their treatments, and then at the 3-month mark the treatments were adapted for their radiographic responses. So patients with complete responses received nivolumab alone, patients with progressive disease received cabozantinib alone, and patients with partial response or stable disease were randomized to either nivolumab maintenance per Checkmate 214 versus cabozantinib with nivolumab. We discontinued treatments for patients who had progressive disease, unacceptable toxicities, or complete responses at 1 or 2 years. Of note, we enrolled 1,111 patients across the cooperative groups over a period of about 5 years, from May 2019 to 2024. We saw that these patients were very diverse and representative, I think, of U.S. populations. More than 10% were Hispanic, Latinx, and also more than 8% were Black, Asian, or American Indian populations. And so that's a really key takeaway from PDIGREE, is that we are able to enroll very large patient population across the U.S. cooperative groups. For your question about the patient distribution to step 2, we saw a good number of patients with intermediate risk disease go on to step 2, not as many with poor risk disease go on to step 2, and then also the presence of bone metastases made a difference. So patients with bone metastases, about 27% of them enrolled to PDIGREE, but only about 24% in step 2 enrollment actually made it into step 2, compared to about 34% of patients in that step 1 withdrawal category. So importantly, we saw about 2/3 of these patients actually make it into the step 2 portion of the trial, and these patients tended to be those who responded well. And to the question of whether this was representative of Checkmate 214, I think our patient population was probably a little bit more frail. We had a little bit more lenient and eligibility criteria for patients treated on PDIGREE, and so the patients who made it into step 2 for essentially on Checkmate 214, who had nivolumab maintenance, those patients all had all 4 cycles of ipilimumab and nivolumab and went into step 2 portion. Our patient population was probably, because they were a bit more frail, there were more de novo metastatic disease, we had a little bit more losses for adverse events during step 1. There about 10% of patients had complete responses on Checkmate 214. We didn't see as many patients achieve that complete response at 3 months, and this was compared to median time to complete response on 214 was about 7 months, so that wasn't too unexpected. And then finally, the progressive disease category was about 20% on Checkmate 214, and it's about what we saw for patients going on to step 2 with progressive disease in PDIGREE. So we haven't drilled down all the way to radiographic responses, but the patients who had partial responses and stable disease who were randomized, we know those patient population that made it into step 2, fewer patients with bone metastases, fewer patients with poor risk disease made it into step 2. And so I do think it represents a real world practice of when we're seeing patients with very symptomatic disease, maybe the bone metastases are more symptomatic, and then also poor risk disease where they have a lot of inflammatory symptoms. Sometimes we're using our VEGF-IO combinations earlier for more disease control, early disease control for those patient populations compared to using ipilimumab, nivolumab upfront. But PDIGREE informs that sequencing approach, and hopefully we can identify the right patient population who would benefit from upfront CTLA-4 blockade as well. So I think there's a lot of potential. We still haven't reached the primary endpoint of overall survival, so that's still to be determined. The more time we wait for the events to occur and mature, the better for our patients. But in the meantime, I do think thinking about patients with poor risk disease, bone metastases more as they're coming into our clinics, if they're very symptomatic from disease, maybe we're choosing a different therapy. There's a lot of potential and opportunities within PDIGREE to identify correlatives and features for potential biomarkers for patients who were enrolled on PDIGREE in terms of finding the patient cohort most likely to benefit from ipilimumab and nivolumab. So all of that work from bank tissue, from centralized imaging, that's all going to be an ongoing piece of work in the cooperative group setting, in the years to come. It's a great question. Correlative work is certainly something that we absolutely need to do and undertake on PDIGREE. In these trials, we often get to a positive primary outcome before we go into the exploratory analyses about correlative studies. So for now, we've banked a lot of samples from tissue to plasma and also radiographic images. And so eventually we'll get there, but not quite yet. And I'm hopeful that by the time we do all of these analyses, we'll see things like transcriptomics, plasma biomarkers like cytokines or PBMCs. All of those inform what we do to validate in PDIGREE. PDIGREE was designed and enrolled over a course of about 10 years, with the open enrollment being between May of 2019 and May of 2024, spanning a pandemic, as well as 7 industry phase 3 trials which read out during that time. So it's a really testament to all of the investigators and sites that had PDIGREE open, and we're so proud of finishing that enrollment and helping our practices, inform our practices of how we can use immunotherapy doublets for metastatic kidney cancer.